All right, so hi everybody, my name is Anna and I'm a PhD student in the Health Research Methodology program. Today I will be presenting methods and results of the evidence synthesis that was used to inform the 2022 clinical practice guidelines for the management of acute dental pain. So I personally have no conflicts of interest to disclose. This project was financially supported by the Food and Drug Administration, or the FDA, of the United States Department of Health and Human Services, or HHS. The contents are those of the authors and do not necessarily represent the official views of nor an endorsement by FDA, HHS, or the US government. The findings and conclusions in this presentation are those of the authors and do not necessarily reflect the official views, position, or policy of the American Dental Association, nor does this presentation constitute an endorsement by the American Dental Association. So in both Canada and the United States, opioids represent one of the most widely prescribed classes of medications. According to the United States Centers for Disease Control and Prevention, or CDC, a large increase in the use of opioid pain relievers has led to one of the worst drug overdose epidemics in the United States history. In dentistry, a study with 500,000 dental patient visits between 2011 and 2015 showed that 29% of prescribed opioids exceeded the recommended dose for appropriate management of acute pain, and over half exceeded the recommended days of supply. The previous clinical practice guidelines lack evidence-based guidance on effective management of acute dental pain, as well as implementation of best therapeutic strategies to reduce reliance on opioids. Therefore, to inform the new 2022 evidence-based clinical practice guidelines for the management of acute dental pain, in partnership with the United States Food and Drug Administration, or the FDA, the American Dental Association, or the ADA, and the University of Pittsburgh and the University of Pennsylvania School of Dental Medicine, our team performed an evidence synthesis, and in this presentation, I report on the details of the methods and the results. So in this evidence synthesis, we had four main objectives that included the assessment of the comparative effect of pharmacological interventions for the management of acute dental pain, including pain subsequent to simple and surgical tooth extraction, and pain associated with pulpitis, or the inflammation of the dental pulp and its complications. So objective one focused on comparing acetaminophen, NSAIDs, opioids, and combinations to placebo. This objective will be the focus of this presentation, and the other three objectives are being presented by my colleagues in other sessions. So in order to achieve objective one, we performed a systematic review and network meta-analysis. We know that a meta-analysis is a statistical analysis that combines the results of multiple studies to compare two interventions. A network meta-analysis allows for comparisons of three or more interventions simultaneously, and in addition to making direct comparisons, it allows to make indirect comparisons. For example, we can see a network plot on the right with every blue node denoting an intervention included in the network meta-analysis. The line in light blue is showing us direct evidence for the comparison of lithium to haloperidol, and the line in dark reds, or the lines in dark red, are showing us indirect evidence for the comparison of lithium to haloperidol through a common comparator, which in this case is placebo. So for objective one, our methods included searching Medline, Embase, Central, and US Clinical Trials Registry on November 21st, 2020. We included randomized clinical trials of participants undergoing dental extractions comparing 10 different interventions, including acetaminophen, NSAIDs, opioids, and combinations to placebo and to each other. These interventions were selected by the guideline panel as the most relevant after a prioritization exercise that considered more than 30 different drugs as monotherapies or combinations. The next step was to conduct a network meta-analysis. So for each outcome of interest, which included pain relief, total pain relief, some pain intensity difference, global efficacy rating, rescue analgesia, and adverse effects, we assessed the risk of bias of each included study using a modification of the Concurrent risk of bias 2.0 tool. We assessed the certainty of the evidence of each outcome using the grading of recommendations, assessment, development, and evaluations, or GRADE approach. The certainty of the evidence was assessed to determine how trustworthy the evidence is with respect to risk of bias, inconsistency, indirectness, publication bias, and imprecision. The assessment of the certainty ranged from high to very low. So for objective one, after screening 4,716 titles and abstracts, 82 unique randomized controlled trials were included to answer this objective. So all studies were parallel group RCTs. Most studies were conducted in the United States of America, 75%. Number of participants ranged from 31 to 540. Mean age of participants across studies varied from approximately 14 to approximately 41 years of age. Surgical tooth extraction was the type of extraction performed in all included studies. So this table presents our results. The interventions are listed as rows and outcomes are listed as columns. On the right, you can see the legend, which explains the color coding in the table. This color coding strategy considered both the magnitude of the effect as well as the certainty of the evidence. High and moderate certainty evidence was color coded from green to red. Green were among the best interventions and red were among the worst of the interventions. Low and very low certainty evidence was color-coded from light gray to dark gray. Light gray were among the best and dark gray were among the worst. So based on this color coding, we can see that for the pain relief outcome, non-steroidal anti-inflammatory drugs or NSAIDs, such as ibuprofen and naproxen, with or without acetaminophen were among the best of the included interventions, whereas opioid including interventions, with the exception of acetaminophen plus oxycodone, were among the worst of the included interventions. As we can see, the results for TODPAR, SPID, global efficacy rating, and rescue analgesia were similar. So just to go over the interpretation of the magnitude of the effect, let's look at pain relief for ibuprofen plus acetaminophen. The magnitude of the effect for pain relief following ibuprofen 200 to 400 milligrams plus acetaminophen 500 to 1000 milligrams can be interpreted as 1.68 points higher than placebo on a scale from 0 to 4. And with respect to adverse effects based on low and very low certainty evidence, most interventions were classified as no more harmful than placebo. So now in terms of the strengths of the review process, each of the review process stages were conducted in duplicate and conflicts were adjudicated by a third reviewer. We assessed the risk of bias in each individual study and the certainty of the evidence for each of the outcomes of interest. We performed analyses and interpreted the results using the latest methodological guidance from the GREAT Working Group. In terms of the limitations of the review process, one limitation was that this systematic review and network meta-analysis was limited to only 10 interventions, which may limit its applicability. However, these 10 interventions were chosen by a panel of clinical experts who determined that these 10 were among the most relevant to clinical practice. Another limitation was that we only included studies published in English, but we believe it is unlikely that our conclusions would have been different if we had included studies that were in a different language. So in conclusion, non-steroidal anti-inflammatory drugs or NSAIDs with or without acetaminophen have shown to be superior among the included interventions with respect to pain relief, total pain relief, global efficacy rating, and rescue analgesia. With respect to adverse effects based on low and very low certainty evidence, most interventions were classified as no more harmful than placebo. Evidence regarding the effects of the 10 selected analgesics on the temporary management of symptomatic pulpitis or its complications prior to dental treatment was not found. Also, evidence for 2 of the 10 selected interventions, which were ibuprofen 200 milligrams plus hydrocodone 5 milligrams, and hydrocodone 5 milligrams plus acetaminophen 300 to 325 milligrams, was not available, and future research on these analgesics is needed. These are my references. Thank you. I'm happy to take any questions.